Today's Fern educational session involves critical long COVID symptoms, brain fog and headache, fatigue and weakness, and chronic inflammations. What are their pathologies, how to clinically diagnose these patients, and how to optimize patient outcomes. My name is Edward Sloan. I'm Professor Emeritus in the Department of Emergency Medicine at the U of I in Chicago, and I'm Medical Director of the PA Studies Program at Dominican University in River Forest, Illinois. I am Fern President and Board Chair. I have no financial conflicts. You can find this information on our fern.org website and our YouTube channel at fern.org. This is a screenshot of our playlist page. I encourage you to go there for more neurological emergencies information. This is my contact information QR. The educational objectives for this session involve a recap of the COVID-19 pandemic and a discussion overview of long COVID. We will then discuss in more detail the COVID-19 pathology caused by the initial viral infection. We will discuss neurological complications seen with acute COVID-19 illness. And then we will begin to discuss long COVID patient pathology, including brain fog and headache, fatigue and weakness, and chronic inflammation. Lastly, we will discuss therapies and lifestyle approaches that can be used to enhance the outcome of patients who have long COVID. COVID-19, the pandemic, and long COVID. The COVID-19 pandemic began in December 2019 with the emergence of a highly transmissible coronavirus, COVID-19, likely from Wuhan, China. Then pursued a 2-year public health crisis that involved the virus infecting millions of patients, causing significant morbidity and mortality. Since the time of the pandemic, there have been long-term effects that have been seen, and a prolonged recovery that has caused ongoing health and lifestyle issues for millions of patients, resulting in significant patient morbidity. 3 of these most important long COVID symptoms include brain fog and headaches, fatigue and weakness, and chronic inflammation. What is long COVID and how is it defined? Long COVID is generally defined as the persistence or emergence of a wide range of symptoms after the initial acute phase of COVID-19 has resolved. Multiple definitions of this multifaceted clinical problem exist. The World Health Organization defines long COVID as symptoms that typically begin within 3 months of the initial SARS-CoV infection and persist for at least 2 months without an alternative diagnosis explaining them. The Center for Disease Control in the U.S. defines it as an infection-associated chronic condition that includes a spectrum of symptoms that emerge or persist well beyond the acute phase of the COVID-19 infection. Lastly, the National Academies of Sciences, Engineering, and Medicine recognize 200 different symptoms that are seen to persist long after the initial COVID-19 infection. What is the epidemiology of long COVID? Up to 60% of long COVID patients experience symptoms such as brain fog, headache, and cognitive complaints. The persistent fatigue and weakness is seen in up to 74% of survivors who then suffer chronic fatigue following COVID-19 infection. In parallel, chronic inflammation has emerged as a key underlying mechanism in long COVID, with elevated biomarkers such as interleukin-10 and C-reactive protein correlating with the persistence of both neurological and systemic symptoms. The epidemiological studies suggest that long COVID, including these 3 symptom clusters, affect approximately 1 to 2.5% of all COVID-19 survivors, translating to tens of millions of individuals globally who have persistent symptoms following the acute COVID-19 infection. In discussing individual symptoms seen with long COVID and their pathophysiology, our first discussion is with brain fog and headache. These symptoms are thought to arise from neuroinflammatory processes that disrupt the normal neurotransmitter signaling and compromise the blood-brain barrier. This leads to an impaired cognitive processing function and altered pain perception. Evidence also suggests that there's persistent microglial activation and changes in key biomarkers like nerve growth factors that underlie these neurological symptoms. Regarding long COVID pathophysiology and the symptoms of fatigue and weakness, these symptoms appear to be linked to mitochondrial dysfunction and impaired energy metabolism, resulting in reduced cellular energy production that manifests itself as post-exertional malaise and diminished muscular function. This metabolic impairment is often compounded by systemic immune dysregulation, bearing similarities to mechanisms observed in chronic fatigue syndrome. Regarding the chronic inflammation seen with long COVID, this inflammation is characterized by sustained immune activation with elevated pro-inflammatory cytokines such as IL-6 and IL-10 that contribute to tissue injury and a prolonged inflammatory state. These interrelated pathophysiological processes collectively explain the whole constellation of symptoms seen with long COVID, highlighting a complex interplay between neuroinflammation, metabolic disturbances, and persistent immune activation. Regarding the patient presentation, when patients are suffering from long COVID, there are several symptoms to consider. Neurological symptoms include brain fog and dull headache, also include difficulty concentrating, memory lapses, and persistent dull head pain. These undermine daily activities and overall mental performance. Post-infectious fatigue studies show that patients report profound fatigue and generalized muscle weakness that cause post-exertional malaise that severely limits physical endurance. Simultaneously, chronic inflammation demonstrates persistently elevated pro-inflammatory cytokines such as IL-6, IL-10, C-reactive protein that suggest ongoing tissue inflammation and injury and sustained immune activation. These overlapping clinical features, cognitive impairments, severe fatigue, and systemic inflammation, show the complexity of long COVID, highlighting the need for multidisciplinary management. How is the diagnosis of long COVID made, given it is complex and multi-symptomatic? Clinicians rely on a detailed patient history, neurocognitive assessments including tests for memory, attention, and executive function, and MRI to detect subtle neuroinflammatory changes in patients who complain of brain fog and headache. Patients with persistent fatigue and weakness are evaluated through comprehensive physical examinations, exercise tolerance tests, and lab tests such as metabolic panels and measurements of lactate. Chronic inflammation is typically assessed by measuring biomarkers such as C-reactive protein, interleukin-6, and other inflammatory cytokines. So what are the long COVID disease mechanisms observed? Testing in brain fog and headache patients has shown reduced nerve growth factor and altered cytokine levels in affected individuals. Persistent fatigue and weakness patient testing has revealed mitochondrial dysfunction and energy metabolism disturbances. Lastly, chronic inflammation has demonstrated ongoing immune dysregulation and sustained inflammatory responses in symptomatic COVID-19 patients. What are the current therapies utilized to help long COVID patients with their symptoms? For patients experiencing brain fog and headache, therapies integrate both cognitive rehab with low-dose naltrexone, selective serotonin reuptake inhibitors, SSRIs, and neuromodulatory agents like guanfacine combined with N-acetylcysteine to reduce neuroinflammation. Fatigue and weakness patients benefit from rehab strategies such as graded exercise programs, energy conservation techniques, and transcutaneous electrical nerve stimulation, TENS, to boost neuromuscular performance and reduce post-exertional malaise. To address chronic inflammation, clinicians commonly employ targeted anti-inflammatory therapies such as low-dose corticosteroids and immunomodulatory agents to lower what are pro-inflammatory cytokines to restore a normal immune balance. What are the expected outcomes in long COVID patients? Many long COVID, brain fog, and headache patients experience gradual cognitive improvement as evidenced by normalization of neuroinflammatory biomarkers and enhanced neuroplasticity documented in serial imaging studies using MRI. Multiple meta-analyses and prospective cohort trials have revealed that fatigue and weakness tends to diminish over a period of several months, with patients progressively regaining functional energy and exercise tolerance. A significant subset of patients show a reduction in chronic inflammation with declining levels of pro-inflammatory markers and C-reactive protein following targeted interventions. These improvements are often achieved through a multidisciplinary approach that integrates pharmacologic therapies, cognitive rehab, and gradual physical reconditioning. What are the societal issues that surround the occurrence of long COVID in the millions of patients who have sustained COVID-19 acute infections? The persistent symptoms seen with COVID-19, including neurological symptoms, leads to significant lost productivity and increased healthcare visits, driving up societal and individual costs. The persistent fatigue and weakness necessitates long-term rehab and support, which directly impacts the quality of life of these long COVID patients and strains public health resources. The chronic inflammation seen with long COVID often leads to complications that require ongoing complex management, which also increases healthcare costs. The combination of diminished work capacity, increased medical expenditures, and limitations in high-quality care for underserved communities underscores the multifaceted societal challenge posed by long COVID, and it highlights an urgent need for comprehensive public health strategies that can improve cost efficiency, quality, and access to care for long COVID patients. So our conclusions regarding our overview of COVID-19 and long COVID patients. The disease. The COVID-19 pandemic was a remarkable world event. The virus caused a wide range of long COVID symptoms, including brain fog and headache, fatigue and weakness, and chronic inflammation. Long COVID is defined for patients as having varied persistent symptoms following the COVID-19 infection that are not otherwise explained. Long COVID is seen in 1 to 2.5% of COVID-19 infected patients. Symptoms such as brain fog, headache, fatigue, and weakness are seen in up to 74% of patients who have survived the acute COVID-19 infection. Chronic infection following COVID-19 infection can be detected by measuring CRP, IL-6 and IL-10 levels, and levels of other inflammatory cytokines. In conclusion, regarding our discussion of long COVID, we then consider mechanisms and the diagnosis of long COVID. The mechanisms for brain fog and headache symptoms include reduced nerve growth factor, microglial activation, blood-brain alterations, and chronic neuroinflammation. The mechanisms for persistent fatigue and weakness include mitochondrial dysfunction and energy metabolism disturbances. The mechanisms for chronic inflammation include ongoing immune dysregulation and sustained inflammatory responses, as seen with elevated inflammatory cytokines. The clinical diagnosis, therefore, of long COVID relies on a detailed history and physical exam, as well as specialized tests such as neurocognitive assessments, brain MRI, exercise tolerance tests, metabolic panels, lactate and nerve growth factor tests, and tests for chronic inflammation. In conclusion, regarding long COVID and our treatments and outcomes, patient treatments for brain fog and headache include cognitive rehab, SSRIs, naloxone, and neuromodulatory agents that reduce neuroinflammation. Patient treatments for fatigue and weakness include graded exercise programs, energy conservation techniques, and TENS use. Patient treatments for chronic inflammation includes low-dose corticosteroids and immunomodulatory agents. Patients are seen to have gradual cognitive improvement, reduced neuroinflammation, and MRI-proven enhanced neuroplasticity with treatment. Patients with fatigue and weakness symptoms see these symptoms diminish over months with progressive improved functional energy and exercise tolerance. And a reduction in chronic inflammation is seen following targeted patient anti-inflammatory interventions. And in conclusion, regarding the long COVID societal issues, we see that there is significant morbidity, healthcare costs, and societal costs that are associated with long COVID as a disease and the care of these patients. Lost productivity, increased healthcare visits, long-term rehab, and a disrupted quality of life all strain private and public health resources. Complications that require ongoing complex management, a diminished work capacity, and increased medical expenditures all impact the health of the public. And we note that there are limitations in high-quality care options for underserved communities and their patients with long COVID. There is therefore a multifaceted societal challenge posed by long COVID and an urgent need for comprehensive public health strategies that improve cost efficiency, quality, and access to care for long COVID patients. What then, therefore, are our recommendations regarding long COVID patient management? It is key to continue to monitor the scope and extent of long COVID disease. It is necessary to support research into the mechanisms of long COVID symptoms and to explore novel mechanisms and treatments for these long COVID symptoms. It is important to assess the societal costs associated with long COVID and to enhance access to long COVID patient care for all patient populations. It is useful and helpful to create a supportive public health environment for long COVID patients and to educate clinicians and patients about long COVID, the disease. So our first educational objective is to discuss COVID-19 and the acute infection seen and the pathophysiologies observed during the acute COVID-19 pandemic. We will discuss the COVID-19 virus pathophysiological mechanisms. What were the COVID-19 injury mechanisms observed during the acute pandemic? With COVID-19, it was observed that there is diminished arterial blood flow and lung dysfunction with resultant tissue hypoxia. Mitochondrial dysfunction was observed and microthrombosis in the arterioles. CSF outflow disruption was seen. Increased CSF glutamate levels were observed. gut dysbiosis was seen, and there was direct cell death in virtually every organ tissue observed. Let's discuss some of the CNS mechanisms seen with the acute COVID infection during the pandemic. The COVID-19 virus was seen to use the ACE2 receptor for access to the cells in the body, especially in neurological tissues. It entered the brain through the nasal olfactory epithelium and through CNS capillary endothelial lining cells. This caused the potential for cerebral edema prior to diffuse organ system loss of homeostasis. Another CNS mechanism was direct infection that caused hypoxic injury, given that it's a respiratory pathogen using the ACE2 receptor, and causing immune injury through the SIRS accelerated and excessive inflammatory response. It also caused toxic encephalopathy through direct infection and viral encephalitis and acute cerebrovascular disease. Additional CNS mechanisms include neuromyopathy, encephalitis, Guillain-Barré syndrome, seizures, status epilepticus, transverse myelitis, and flaccid myelitis. These symptoms are seen with many viruses, not just the coronavirus, but there is a direct neurotropism of these viruses that suggest that neurocells and neurotissues are at greatest risk. The affinity of the COVID virus for nerve tissues explains why there are so many observed CNS complications with acute and chronic COVID-19 infection. Another proposed and observed mechanism for COVID-19 complications is cytokine storm. With COVID-19 infection, both IL-6 and IL-10 were observed to be elevated, and the ratio of IL-6 to IL-10 seemed to predict some complications during cytokine storm with COVID-19 infection. There's also a sympathetic storm seen with COVID-19. This causes a dysautonomia. There's direct autonomic pathway neuronal injury, immune-mediated injury, sympathetic nervous system activation, inhibition of the parasympathetic system. There are sympathetic and cytokine storms, therefore, that activate the renin-angiotensin system. With COVID-19 acute infection and sympathetic storm, we see both cardiopulmonary complications and neurological sequelae that directly result, likely, from these abnormal cytokine and sympathetic storms. Our second educational objective is to examine acute COVID-19 neurological illness and injury seen early and during the pandemic. Early on, from observational case series from Wuhan, China, several hundred patients demonstrated that 40% or more had severe neurological complications in 3 different categories. CNS categories including dizziness, headache, altered mental status, stroke, ataxia, and seizure. Peripheral abnormalities such as taste, smell, vision abnormalities, and nerve pain. And skeletal muscle injury as a neuromuscular complication. Regarding COVID-19 headache, a Medline search of 41,000 patients who were described during the pandemic demonstrates that headache was seen in up to 12% of patients in 2 phases: acute headache in the viral infection phase, and headache later associated with hypoxia and with the ongoing cytokine storm. More information regarding acute COVID-19 headache symptoms. It was recorded in up to 1/3 of hospital COVID-19 patients, the headache being described as bitemporal, frontal, or periorbital. It often was new with sudden or gradual onset, rated moderate to severe, as a throbbing or pressure with a poor analgesic response. There was an observed high relapse rate for headache during the acute infection, and the observed peripheral trigeminal nerve ending problems related to pro-inflammatory hypoxia and/or cytokine storm. Regarding the COVID-19 CNS complications, myalgia and headaches are common. Direct viral invasion of all neurological tissues was seen, causing myopathy, polyneuropathy, rhabdomyolysis, meningitis, and encephalitis. It was frequently observed that anosmia and ageusia, the loss of smell and taste, were seen in many COVID-19 patients. Also observed were post-viral autoimmune processes, encephalomyelitis, and Guillain-Barré syndrome. Now, what were some of the neurological sequelae seen in patients with COVID-19 during the acute pandemic? One study of 43 UK patients demonstrated encephalopathies, inflammatory CNS syndromes, stroke, Guillain-Barré syndrome, and brachioplexopathy. Another study during the acute COVID-19 infection demonstrated altered mental status and coma. In this case report, a 64-year-old Chinese patient with no medical history, a fever up to 38.5, cough, myalgias, developed lethargy and unresponsiveness 13 days later. In this patient, dissociated speech, ankylosing, Babinski and Chaddock signs, and meningismus were observed. The CT and LP were negative, and the patient did recover and was discharged 17 days later. Another patient case report demonstrated an acute COVID-19 meningitis bout. This 24-year-old patient, 9 days into an episode with fever, headache, and fatigue, became unresponsive, had an episode of emesis, and was found lying on the floor. There was transient generalized tonic-clonic seizures observed, and CSF COVID-19 was detected. The MRI was positive in the lateral ventricle, temporal lobe, hippocampus, all suggesting meningitis. 2 case reports demonstrated the complication of meningoencephalitis in the acute COVID-19 phase. A 64-year-old woman with no psych history was admitted to the psych ward and then had tonic-clonic seizures consistent with focal status epilepticus. The MRI was normal, but the LP showed meningoencephalitis. The patient was treated with acyclovir and improved over 4 days. A second case report involved a 67-year-old woman who was COVID positive for 17 days. She one day had an intense wake-up headache, was confused, had bathroom syncope. She was found to have a left-sided stroke. The MR was okay. She had CSF pleocytosis. She was treated with acyclovir antibiotics and was discharged after 4 days. Another complication of acute COVID-19 infection was orbital cellulitis. A 12-year-old Egyptian male was seen with 3 days of orbital swelling. The patient had orbital cellulitis, surgery, and antibiotics to effect a cure. A 15-year-old male had 3 days of orbital swelling, was treated with ceftriaxone and vancomycin. The CT showed pansinusitis, orbital cellulitis, and an epidural abscess. This patient required surgery and had a complicated course. The acute COVID-19 infection was also seen to cause cereballitis. The case report involved a 63-year-old male with altered mental status and ataxia. The patient had had COVID-19 5 days prior. The neurological exam demonstrated cerebellar symptoms, a broad-based gait with truncal ataxia. Imaging revealed white matter degeneration and edema of the cerebellar hemispheres. The symptoms in these patients completely resolved with COVID-19 treatment with corticosteroids and intravenous remdesivir. The MRI in this case showed bilateral cerebellar white matter signal abnormalities in this patient with COVID-19 cerebellitis. The acute COVID-19 infection was also seen to cause transverse myelitis. 1.2% of all COVID-19 neurological complications involve transverse myelitis. The baseline incidence for this acute disease is much less at 0.003%. So this represents a 400-fold increase in the rate of transverse myelitis as a result of COVID-19 infection. 2 case reports include a 56-year-old with leg weakness and urinary retention, and a 43-year-old with fever, sudden onset of both lower limb numbness, weakness, inability to sit, and urinary symptoms. An example of the inflammation seen with COVID-19 and transverse myelitis is observed in this T2 image from the spine, showing abnormal cord signaling extending from the cervical C2 down to the thoracic T11 vertebral level, seen with the faint red arrows. Also seen with acute COVID-19 infection were CNS thrombosis cases. A representative case report here is a 64-year-old male who had a wake-up stroke, left hemiparesis. No TPA was provided. 16 days prior, the patient had had fever, myalgias, and COVID-19 infection. The patient had tachycardia, hypertension, hypoxic respiratory failure, and required endotracheal intubation. The CT showed hypoattenuation and loss of gray-white matter differentiation. The CTA showed an internal carotid artery high-grade stenosis, but otherwise no IC occlusion. A repeat CT at 24 hours demonstrated cerebral edema, mass effect, and a right MCA and ACA territory involvement. COVID-19 acutely was also seen to cause CNS venous thrombosis. A case report here is of a 59-year-old male, 4 days of frontotemporal headache, diabetes, hypertension, persistent severe headache, and fever. The patient had CT superior sagittal, transverse sigmoid sinus, and IJ vein densities suggesting of thrombosis. The CTV was otherwise negative. 4 days later, when the patient developed stroke symptoms of unilateral weakness, slurred speech, and expressive aphasia, the CTV was reread as showing sigmoid and transverse sinus defects. Low molecular weight heparin was provided, and the patient's NIH stroke scale went from 10 to 4 over 24 hours, and the patient was successfully discharged home. Regarding acute COVID-19 thrombosis and the sequelae of this complication, one review suggested that hypercoagulability was the cause of this complication, and that it caused acute cerebral vascular disease, acute ischemic stroke, acute disseminated myelitis, as well as Guillain-Barré syndrome. A true viral encephalitis was actually more rarely seen than the encephalopathies associated with the complications of the COVID-19 virus acute infection. Regarding COVID-19 and thrombosis, the thrombosis was associated with the initiation and amplification of the coagulation cascade in small arterioles throughout the body. This was seen as a result of the disrupted endothelial barrier and clots in arterioles in all body tissues. Regarding acute COVID-19 mechanisms seen in pediatric patients, several are proposed and have been observed, including endothelial injury, direct viral effects, post-infectious inflammation, and para-infectious inflammation, and symptoms seen with long COVID. Our conclusions regarding COVID-19 pathology during the acute infection and the COVID-19 pandemic. COVID-19 acutely causes a viral infection with secondary infections that result. There is both direct neuron and CNS tissue toxicity from this coronavirus. There is endothelial damage in the arterioles in every tissue of the body. SIRS and inflammatory effects also are seen as a result of the acute COVID-19 infection. These inflammatory processes cause complications not directly caused by the virus itself, and the thrombosis seen in the arterioles in the tissues and organs throughout the body have been associated with the complications seen with acute COVID-19 infection. In summary, COVID-19 acutely was observed to cause significant neurological complications and adverse effects in every age group. Our third educational objective when considering long COVID patient symptoms involves the symptoms seen acutely with COVID-19 infection. A 2021 publication, a systematic review and meta-analysis utilized 15 papers and identified 55 long-term COVID-19 effects from the 48,000 patients who were studied. Up to 80% of COVID patients were seen to have at least one long-term symptom. And we note that subsequent variants, which are less virulent, may cause fewer long-term symptoms. Regardless, these symptoms included fatigue, headache, ageusia, anosmia, hair loss, nausea, pulmonary symptoms, dyspnea, shortness of breath, extremity pain, fatigue, and weakness. As we continue to examine COVID-19 long COVID patients' pathology, we will first discuss brain fog and headaches. A representative case is a 42-year-old female with a history of COVID-19 infection. This patient had a history of migraines that had been under control. But following COVID-19 infection, the patient now complains of brain fog with poor work functioning during the day and onset of typical migraine headaches as the day progresses. The patient asks, when will the brain fog go away? And how do I prevent these recurring migraine headaches? These are the questions that the emergency physician or primary care clinician needs to consider. In the 2021 study that identified 55 different symptoms related to COVID-19 infection, 25% of COVID patients were seen to have attention symptoms and 50% were seen to have headache symptoms. Regarding the brain fog and headaches seen in COVID-19 patients, some patients had a new onset of headaches and some had a recurrence or worsening or increased severity of their typical migraine headaches. But in addition, patients were observed to have lack of ability to concentrate, poor memory, changes in cognition, lost higher level of cognitive skills, and anxiety and depression related to these brain neurological symptoms. Regarding the brain fog symptoms themselves, these included a disorder of executive function, the ability to focus, hold on to critical information, and block out distractions when attempting to do something. It's not seen as a mood disorder, and it appears to be related to cell and CNS tissue changes and physiological changes in the central nervous system. So again, the long COVID neurological symptoms include up to a half with headache and about a third with brain fog. Attempting to identify more information related to brain fog and headache, An AI search and input from Copilot demonstrates the following. One of the possible mechanisms related to brain fog and headache appears to be spike protein persistence. Research has shown that the SARS-CoV virus spike protein can remain in the brain protected tissues and skull bone marrow for years after infection. This persistent presence can trigger chronic inflammation and increase the risk of neurodegenerative conditions. There also appear to be brain structural changes in patients who have brain fog and headaches. These changes, as demonstrated on MRI studies, include structural alterations in the brains of long COVID patients. These changes include decreased brain volume in specific regions and reduced cortical thickness, which are associated with cognitive impairments. AI has also demonstrated that there are studies that support the concept that poor lung gas exchange and brain fog appear to be related. That is to say, poor lung functioning may be the link between cognitive difficulties and the occurrence of the COVID infection. With reduced gas exchange in the lungs and reduced intake of oxygen and clearance of carbon dioxide, there may be an associated brain fog and changes in brain structure. Lung abnormalities with COVID infection may also influence brain blood flow. That is to say, there is research that suggests that poor lung function may lead to an increased blood flow to the brain as a compensatory mechanism in an attempt to deliver more oxygen to the brain when lung function is compromised. So there appear to be efforts by the body, the lung and the brain, to have an improved homeostatic function of both organs. Brain fog and headache. What are the anatomical changes seen in these patients with long COVID symptoms? One study identified multiple neuronal cell changes and myelin deregulation. This animal study demonstrated changes in neurogenesis with COVID-19 infection. In this mouse model, cytokine and chemokine changes were noted associated with cognitive decline. There were changes in the hippocampus, microglia, and impaired neurogenesis. In essence, the respiratory COVID infection caused a persistent loss of oligodendrocytes and myelinated axons, and these are seen more with COVID-19 infection than with common respiratory flu illnesses. This study also demonstrated that COVID-19 causes a decrease in the number of neurons. There are three possible mechanisms for this: fewer cells themselves, less myelinization of neurons, and less neurogenesis following or with nerve cell turnover. Another SARS-CoV study looked at changes in brain structure from a UK biobank. In this publication of 785 participants, the UK biobank demonstrated damage and decreased brain tissue with COVID-19 infection. In patients between 50 and 80 years of age, 401 had COVID-19 and 384 were served as controls. There were two different MRIs done so that comparisons could be made, with an average of 141 days between each MRI. These comparison MRIs demonstrated a reduction in gray matter thickness and tissue contrast in the orbital frontal cortex and the parahippocampal gyrus. There were also increased markers of tissue damage in primary olfactory functional cortex regions. There was also a reduction in global brain size in those who sustained the SARS-CoV infection. And during this same time, these patients had a greater cognitive decline during this time interval. These graphs demonstrate a difference in outcome between those who did and did not have COVID-19 infection. In the COVID-19 patients, there was a reduction in gray matter and an increase in tissue damage, showing that the COVID patients had changes not seen in the control patients and their MRIs. There was also a cognitive ability decline in the COVID-19 patients as compared to the controls. Was seen a greater task completion time in COVID-19 patients versus the controls. So, was there a causal effect between COVID-19 and the structural changes in the specific brain regions seen? This randomized study tried to address that. So is there a predisposition to increased atrophy with COVID-19 infection in some patients? Phenotype testing was done. There were thousands of corona-19 viral infection cases and over 1 million controls in this study. In the Enigma Consortium with MRI brain morphometry, atrophy was seen in the following regions with COVID-19 infection: in the caudal middle frontal gyrus, in the lateral orbital frontal and rostral middle frontal gyrus, in the cuneus and pericalcerine, in the superior parietal and perihippocampus gyrus regions. In summary, with COVID-19 infection, there is decreased hippocampus volume and more atrophy seen as compared to changes in control patients. So, with COVID-19, there is increased atrophy in many regions. So there is direct viral invasion of the brain. There are changes in the brain that appear to relate to specific pathologies. In this study that looked at increased brain atrophy that was identified in multiple regions, here is a quote: "Irrespective of the exact mechanism of the associations via a genetic background, our findings provide new evidence for a causal relationship between COVID-19 infection and brain structural changes and suggest possible causes of cognitive impairment after COVID-19. As we continue to consider the long COVID symptoms of brain fog and headache, it's also important to consider physiological changes that may occur independent of anatomical brain and CNS changes. One study from Spain included 83 long COVID patients and 22 matched controls. In these patients, there appeared to be episodic memory, attention, working memory, processing speed, and verbal fluency deficits measured with a cognitive exam. Using MRI brain morphometry, it appeared that there is a thinner cortex and altered white matter connectivity seen in these patients, and there appears to be a relationship between these two findings. The authors note that this study shows that patients with neurological long COVID suffer brain changes, especially in several white matter areas, and these are associated with impairments of specific cognitive functions. These graphs just demonstrate that there is a difference between the case patients who have had COVID and the controls, and there appear to be worse cognitive performance in the long COVID patients. Another physiological study regarding COVID-19 infection and CNS changes included PET scan changes from 45 COVID patients and 52 control patients in the U.S. The patients who had sustained COVID-19 infections had focal areas of hypometabolism in the bilateral frontal, parietal, occipital, and posterior temporal lobes and the cerebellum. So this peaked at 2 and was nearly complete at 6 months and appeared to resolve by 12 months. There was also a hypermetabolism seen involving the brainstem, cerebellum, limbic structures, frontal cortex, and periventricular white matter that was seen between 2 and 6 months after the CNS infection by COVID-19. Patients with older age, acute neurological symptoms, and worse disease severity scores were correlated positively with these metabolic changes observed on PET scan. From this study, the authors comment, the present study demonstrates a pattern of reversible brain PET hypo and hypermetabolic changes in patients with confirmed SARS-CoV infection. And they state, even so, metabolic changes were detected in asymptomatic patients and patients without symptoms, strongly suggestive of COVID-19. Because these changes occurred even in patients with none or mild COVID-19 symptoms, it does suggest we have more to learn about physiological changes seen with COVID-19 infection. So in conclusion, regarding brain fog and headache, what do we know now about the anatomical and physiological changes seen with COVID-19 infection? With COVID-19 infection, brain fog and headache are common. Headache exacerbations complicate patient functioning following the acute COVID infection. Retained bone marrow and meninges C19 spike protein may be one of the causes of long COVID symptoms. There are also structural brain changes seen, including atrophy and specific cell damage. The lung, which may be dysfunctional, and the resultant hypoxia can cause blood flow and hypoxic effects in the brain. With long COVID CNS symptoms, there are attention, fluency, memory, and processing gaps observed. There are reversible over several months PET metabolic changes following COVID infection. And those at-risk groups with the greatest severity or at-risk demographics showed greater PET changes. In summary, in patients who sustained brain fog and headache, we observed both structural and functional changes in the CNS system. And we note that there are temporary physiologic changes that have been observed. What are our recommendations regarding patients who complain of brain fog and headache? It may be useful to consider and treat brain fog and headache in long COVID patients, like patients who sustain a concussion, allowing activities to occur that don't bring on symptoms such as headache. It is important to educate and train patients to do cognitive activities until a headache occurs, which is the endpoint for that session. It's worthwhile for patients to develop a brain workout regimen that works up until a headache endpoint and hopefully becomes progressively longer over time. Patients can focus on activities and cognitive efforts that are their strengths so that their overall cognitive functioning can be improved. And those patients who have frequent recurrent migraines can use preventative medications and pre-treat when they know they are going to have heavy cognitive sessions during the day. Also, it is worthwhile to consider nerve-specific medications in patients who complain of long COVID, brain fog, and headache. Migraine headache prophylaxis in patients with long COVID, brain fog, and headache might be the use of propranolol, antidepressants, anticonvulsants such as valproate, and serotonin antagonists or SSRIs. Also of note is the potential use of CGRP receptor antagonists, which both can serve to prevent migraines and to break or stop a migraine as it is occurring in patients with brain fog and headache. We now would discuss fatigue and weakness in long COVID patients. A typical case presentation might be a 55-year-old female with the history of COVID-19 infection. She states now that she is profoundly weak and fatigued. She's barely able to do any work around the house or even walk the dog without having to rest during or after the episode for several minutes. The patient asks in the emergency department, "Why am I so fatigued? Is this the result of the virus? What can we do to make me better?" As noted in one meta-analysis and systematic review, approximately 60% of COVID patients experience some fatigue symptoms at some time during or after the COVID-19 infection. So when we consider post-COVID-19 syndrome or long COVID, we are thinking about long-term deconditioning symptoms. And these symptoms are similar to those seen in myalgic encephalomyelitis chronic fatigue syndrome, which is MES. Oh boy. These symptoms are long-term deconditioning symptoms. These are similar to the symptoms to those seen in myalgic encephalomyelitis chronic fatigue syndrome, which is ME/CFS patients. And these include persistent fatigue, diffuse myalgia, depressive symptoms, and non-restorative sleep. The Epstein-Barr virus previously has been the only virus that has consistently been associated with problems such as ME/CFS. What does our Copilot AI search provide to us with regard to this fatigue and weakness? Part of the fatigue and weakness seen in long COVID patients is due to mitochondrial dysfunction. We see that mitochondrial damage in muscle tissues leads to reduced energy production and increased fatigue with muscle use. This damage causes muscle weakness and a decreased capacity for physical activity. Also, there may be persistent inflammatory changes in these long COVID patients that contribute to ongoing fatigue and muscle weakness. This inflammation may be driven by the lingering presence of the COVID-19 spike protein in brain protective tissues and in the skull bone marrow. Also seen following the acute phase of the COVID-19 infection is impaired lung functioning in some patients. So there appears to be a link between impaired lung function and cognitive difficulties in long COVID patients, and it may lead to brain fog and fatigue in these long COVID patients. Also, there are neurological changes seen in the structure of the brain, and these changes are associated with cognitive impairments as well as contributions to the overall feeling of fatigue and weakness in these patients. Besides the other abnormalities seen, there also is an observed autonomic nervous system dysfunction noted in some long-term COVID patients. Dysautonomia or dysfunction of the autonomic nervous system can lead to many symptoms, including orthostatic intolerance, in other words, not being able to get up or stand up quickly, fatigue, and muscle weakness. What are some of the anatomical changes we may observe in patients with long COVID who complain of fatigue and weakness? One study of 120 ICU patients, average age 56, 98 of whom required mechanical ventilation, showed that 93% had short-term physical dysfunction and 11 patients showed abnormalities in muscle biopsy at 9 months. What they found was perturbed muscle repair findings, different prominent muscle fiber types than normal, and decreased capacity for oxidative phosphorylation, which provides energy. From this study, the authors note, survivals of critical COVID have a high prevalence of weakness, fatigue, and reduced functional exercise capacity, with muscle tissue exhibiting a greater abundance of M2-like macrophages and satellite cells and a lower activity of mitochondrial complex 2 and complex 4. In other words, there's both a functional change and an anatomic change following critical COVID disease. So what are some of the physiological changes that we note? As stated, autonomic nervous system dysfunction is a prominent problem. When there is dysautonomia, we note orthostatic intolerance, fatigue, and muscle weakness. So, postural orthostatic tachycardic syndrome, or POTS disease, is manifested by patients who often, when they stand up quickly and change position, will note tachycardia and not feel well and may feel lightheaded. In 87 post-COVID patients and 50 ME/CFS patients and 50 healthy controls, one study tested hemodynamic autonomic function. The POTS rates in both syndromes versus normal was much higher than expected in the normal population. This curve demonstrates that there are different rates of POTS in patients who have had either COVID-19 or ME/CFS. And in these patients, there appears to be impaired cognitive performance, higher fatigue levels, poor sleep quality, depression symptoms, and anxiety symptoms in those who have experienced either of these viral-related syndromes. Looking at heart rate and POTS, or postural orthostatic tachycardic syndrome, we know that about 14% of the post-COVID patients and 31% of the ME/CFS patients meet the diagnosis criteria for POTS. This is much higher than what is expected in a normal population of patients. So these authors note that post-COVID condition, also known as long COVID, and ME/CFS syndrome are characterized both by unusual fatigue, cardiovascular events such as arrhythmias, palpitations, and increased heart rate, myalgias, headaches, non-restorative sleep, post-exertional malaise, and cognitive problems such as brain fog. So in these patients with both of these conditions related to viral infection previously, are noted to have symptoms that are multifactorial and relate to the fatigue and weakness seen in some patients with long COVID. So in conclusion, regarding long COVID patients who sustain fatigue and weakness, we notice that these symptoms are due to long-term deconditioning, with symptoms like those seen with ME/CFS. These include disordered sleep, fatigue, myalgias, depression symptoms. And these are noted to be caused by mitochondrial and muscle dysfunction, persistent inflammation, brain changes, and pulmonary dysfunction. There are significant autonomic dysfunctions noted, with postural orthostatic tachycardia syndrome being much more prevalent in both of these viral-related chronic syndromes. As such, there is a need to treat long COVID patients who have fatigue and weakness using approaches like those used for patients with ME/CFS, addressing physiological abnormalities with reconditioning strategies designed to restore some reasonable level of health conditioning. This is the end of the fatigue and weakness part. We now discuss chronic inflammation as it is noted in long-term COVID patients, and we begin with our Copilot AI input. We notice that one of the big issues is a viral antigen persistence that causes chronic inflammation. There is a spike protein persistence of the SARS-CoV-2 spike protein, and it remains in brain-protected tissues and the skull bone marrow for years after infection. This persistent presence can trigger chronic inflammation due to chronic immune system stimulation and increased neurodegenerative condition risk. Also seen with regard to chronic inflammation are cytokine dysregulation and prolonged immune activation. These are seen in long COVID patients who often exhibit an imbalance of pro-inflammatory cytokines. So there are sustained elevations of mediators like IL-6, TNF-alpha, and interferon gamma that create a state of chronic low-grade inflammation. Endothelial dysfunction and microvascular injury are also noted in some long COVID patients. This damage to the vascular endothelium can lead to microvascular injury, impaired tissue perfusion, and localized hypoxia, all of which can promote the release of inflammatory mediators that sustain chronic inflammation. Latent virus reactivation can also be seen in some long COVID patients. COVID-19 may actually allow dormant viruses such as the Epstein-Barr virus or other herpes viruses to reactivate. These reactivated viruses can further stimulate the immune system, adding layers to the already heightened inflammatory state seen in some long COVID patients. There are also direct neurological changes. Chronic inflammation in the brain, particularly in the areas of the olfactory bulb, has been linked to symptoms such as brain fog, mood disorders, and cognitive impairments. The autoimmunity seen in patients who have been infected with the COVID-19 virus may trigger autoimmune responses that lead to autoantibodies that attack the body's own tissues, causing inflammation and secondary tissue damage. Microclot formation is also a problem that has been seen in patients infected with the COVID-19 virus. When these microclots occur, chronic inflammation can lead to immunothrombosis, where microclots form in the blood vessels, reducing tissue perfusion and causing additional tissue ischemic injury. In the presence of chronic inflammation, persistent cardiovascular issues can also be seen. Some long COVID patients may experience ongoing cardiovascular problems due to chronic inflammations, which can affect heart function and lead to symptoms like chest pain and palpitations. Lastly, chronic inflammation can cause muscle changes that result in muscle weakness, leading to a reduced physical capacity and the need for reconditioning. So in conclusion, regarding long COVID chronic inflammation, we observed that in some patients, viral antigens can persist in the tissues of the body, causing autoimmune reactions, cytokine dysfunction, and endothelial and microvascular injury, all which result in additional inflammation. There can be latent viral reactivation of the Epstein-Barr virus and other herpes viruses that will also induce heightened inflammation. We see that brain and muscle tissues can be chronically inflamed. We note that there are cardiovascular tissue inflammation problems related to autonomic dysfunction and POTS in some long COVID patients at rates seen much higher than in a normal population who had not been infected with COVID-19. As such, clinicians need to treat long COVID patients with chronic inflammation in mind using approaches that reduce inflammation in multiple organ systems. It is also important to note the public health information and advocacy efforts in patients or for patients who are sustaining long COVID symptoms. The National Institutes of Health, NIH, provides information, and there is information from the NIH, NHLBI, that provides research and resources that directly address the symptoms of long COVID. The NIH, the CDC, Center for Disease Controls, and the White House all have published information that relate to the need for patients with long COVID to receive optimal health care in order to improve their outcomes over time. Specifically for the CDC provides many resources that address the issue of long COVID, including reports that update our understanding of this disease and how it can be optimally managed. The 2022 CDC long COVID data said that long COVID is seen in approximately 7% of adults, 1.3% of children, which means up to 18 million Americans have or were sustaining long COVID symptoms. Those at greatest risk for long COVID symptoms include women, those with underlying illnesses, those who had initially severe COVID-19 disease, and those of Hispanic ethnicity. They note that the most common symptoms in long COVID patients are fatigue, brain fog, and post-exertional malaise. And they also note that the COVID-19 vaccine appears to reduce the risk of developing long COVID symptoms. The National Academies of Science also have published a monograph that addresses the issue of long-term health effects of COVID-19, including those symptoms we referred to or that are included in the description of long-term COVID patients. From the National Academies, the following conclusions are noted: that there are complex infection-associated chronic conditions affecting multiple body systems that are not new, and that long COVID shares many features with such conditions as ME/CFS, fibromyalgia, and postural orthostatic tachycardia syndrome, or POTS. This monograph also concludes that the current therapies about the pathophysiology of these conditions include immune dysregulation, neurological disturbances, cardiovascular damage, gastrointestinal dysfunction, metabolic issues, and mitochondrial dysfunction. The Academy suggests that more research be conducted in order to understand the natural history and management of this complex, multi-system chronic condition, which we call long COVID. These symptoms share many features with other chronic conditions such as ME/CFS. What about long COVID awareness and advocacy for patients with long COVID? One article in the San Francisco Chronicle identified the fact that long COVID and the occurrence of it in so many patients has highlighted what has been an ongoing chronic disease in some patients, ME/CFS. In other words, because these symptoms or disease states are so similar, we now have the ability to address issues related to both of these chronic conditions thought to be related to initial viral infection. What about POTS, the postural orthostatic tachycardia syndrome? There is an organization called Standing Up to POTS. It is dedicated to improving the quality of life for people with POTS through focused research, advocacy, and support. And the resources and community-driven programs that they identify hope that the issue of POTS, which is now in the forefront because it has occurred in so many individuals with long COVID, can help to identify ways to optimize the outcome in patients who have similar dysautonomia symptoms. Regarding dysautonomia, an organization called Dysautonomia International has a scope that includes diseases like POTS, and it provides support and advocacy for patients whose long COVID symptoms are a manifestation of some type of dysautonomia. And they have a network of both online and in-person help assistance that connects patients with similar experiences, offering guidance on managing these troublesome and hard to treat dysautonomia symptoms. Recover, researching COVID to enhance recovery, also addresses long COVID patient advocacy. There is something termed the Recover Initiative, whose goal is to make it possible to provide input in the care of long COVID patients so as to improve their outcome optimally. And in fact, the Recover organization or initiative has several publications which are identified on this slide. You can find these at recovercovid.org. So in conclusion, regarding long COVID public health information and advocacy, we see that there's information from the White House, NIH, and CDC, all of which expand patient and clinician awareness for long COVID as a disease. The National Academies has published a monograph that addresses long COVID, and there's advocacy related to ME/CFS that may apply to long COVID patients, and advocacy related to POTS and dysautonomias that are troublesome for many patients, including those who are post-COVID. And lastly, recovercovid.org supports research and recovery, and the Recovery Initiative publications support patient and clinician efforts to improve patient outcomes. Regarding long COVID patient physician action plans, here are some general concepts. It's important for clinicians to listen to symptom descriptions and reaffirm to the patient that these symptoms are real and have been noted in millions of other post-COVID patients. It's important to recognize that long COVID symptoms and those seen with ME/CFS and POTS are related. It's necessary, therefore, to delineate a multi-step approach. And it's important to tell patients directly that improvement is likely to occur over time. Therefore, patient assessments, both their own and by a clinician, need to occur over a longer period of time, such as at holiday intervals. In other words, you can't week to week determine whether you're getting better, but surely in between all major holidays, you can have an assessment that says, I am better than I was several months ago. And it's important to have the patient actively use the scientific method to help in their care. In other words, recording what symptoms occur on what days as a result of what activities or what interventions is an important way in which the patient can feel as though they have some control over this illness that we term long COVID. So patients can collect data such as experiencing brain fog, headache, fatigue, weakness, and any impairments to an optimal lifestyle. So what lifestyle changes can patients initiate with the guidance of their clinicians? It's important to optimize hydration and diet, healthy foods, low fat, low salt, low sugar. Vitamins and adjunct therapies also can be used as they may enhance the return to a normal life following long COVID. It's important to optimize medication use, whether these are pain medications, specific nerve-related meds, or SSRIs. Exercise and guided exertion and activities such as yoga may help with the fatigue and weakness seen in patients with chronic COVID symptoms. Optimal sleep, the use of naps, interval rest, and rehabilitation exercises all may also help patients as they attempt to regain an optimal lifestyle. Meditation, positive thought, faith, and fun, laughter, all of these may help patients as they try to recover from long COVID symptoms. Lastly, limiting the use of drugs, alcohol, and persistent time on screens looking at social media and other content may help with the mental health of patients who are attempting to recover from the physical and mental symptoms related to long COVID. The CDC specifically addresses lifestyle enhancements that can occur in patients with long COVID. These include how to pursue an optimal daily life when treating long COVID. These include ways in which pediatric patients, both adolescents and young adults, can deal with long COVID. The CDC also addresses issues regarding workplace efforts to feel better and perform better even when long COVID symptoms persist. The CDC also addresses visits to doctors and other healthcare clinicians in order to optimize that interaction, telling patients what might you expect, what might you ask, and how can you optimize this interaction with your healthcare clinician. The CDC also identifies support groups and resources that allow individual patients to join in with others to better understand their own disease and their own symptoms and the ways in which other individuals are dealing with it in order to optimize their lifestyle and their mental attitude regarding their treatment of this disease. And also, there are other resources that are available through the CDC regarding long COVID, as noted on this screenshot of one of the CDC's website pages. So in conclusion, regarding long COVID lifestyle enhancements, we know that there's information from the White House, NIH, CDC, all of which expands patient and clinician awareness. We know that there's an academy, National Academy monograph that addresses long COVID specifically. We know that there's advocacy related to ME/CFS that may apply to long COVID patients. And we know that there's advocacy related to POTS and dysautonomias that also may relate to those cardiovascular symptoms seen in some long COVID patients. The recovercovid.org site supports research and recovery, and we know that there are Recover publications that support patient and clinician efforts. Regarding the management of patients with long COVID symptoms, it's important to consider what nerve dysfunction meds might apply from other diseases to the treatment of patients with long COVID neurological symptoms. Regarding long COVID neuropsychiatric care, we know again that COVID-19 is a neurotropic virus. It causes long-term nerve dysfunction, and therefore it's important to consider nerve dysfunction medications such as gabapentin, pregabalin, amitriptyline, and nortriptyline. It's important to care for medical symptoms as they occur and the associated depression and anxiety that may result because of these medical symptoms. We note that anxiety and depression often occur because of the severity of symptoms long term and because of an uncertainty regarding outcome. Patients don't know if they'll ever get better, and this reasonably does cause some degree of anxiety. So regarding the nerve meds gabapentin and pregabalin, these medicines are commonly treating partial seizures, post-herpetic neuralgia, fibromyalgia, and restless leg syndromes. They also have been utilized in migraine headache patients, patients with interstitial cystitis, painful diabetic neuropathies, irritable bowel symptoms, anxiety, and mood disorders. We see that binding of the alpha-2 delta subunit decreases the depolarization-induced influx of calcium into neurons and reduces the release of excitatory neurotransmitters. In other words, these medications can reduce the inflammation seen in nerve cells as they communicate with one another. Two other meds used to treat patients with nerve disorders include amitriptyline and nortriptyline. These are both tricyclic antidepressants. These have been used successfully in patients with depression, chronic pain, diabetic neuropathy, myofascial pain, orofacial pain, post-herpetic neuralgia, smoking cessation, PTSD, and IBS. We see that amitriptyline is a tertiary amine. It has a strong binding affinity to the alpha-adrenergic, histamine, and muscarinic receptors. And it's the consensus that nortriptyline inhibits the reuptake of serotonin and norepinephrine by the presynaptic neural membrane, thereby increasing the concentration of those neurotransmitters in the synapse. When going to AI, we note there are 5 medications that may provide value in patients with long COVID symptoms. One is gabapentin, which we've already noted is used to manage neuropathic pain. It may help with the chronic pain seen in some COVID patients, especially burning sensation in extremities and other tissues. However, its efficacy for COVID-19 induced olfactory dysfunction was not significantly different than that was seen with placebo. So, we know that pregabalin also is used for neuropathic pain, and it has been considered for managing chronic pain and anxiety in some long COVID patients. So, pregabalin may help to reduce symptoms like muscle pain and improve sleep quality. So, amitriptyline, a tricyclic antidepressant seen to treat post-COVID headaches and headaches that resemble tension-type headaches and migraines, is also seen to help in patients with sleep disturbances and chronic pain, such that it may provide value in reducing pain and enhancing restorative sleep in patients with long COVID symptoms. Nortriptyline, which has a similar purposes as amitriptyline, does help also with managing chronic pain, improving sleep, and alleviating symptoms of depression and anxiety in patients with long COVID. So in conclusion, regarding long COVID nerve dysfunction meds, we note the following. Gabapentin successfully targets neuropathic pain and the burning sensations noted in some long COVID patients. Gabapentin, however, did not improve COVID-related smell loss in clinical trials. Pregabalin helps to manage neuropathic pain, anxiety, and sleep issues in some long COVID patients. Amitriptyline effectively treats post-COVID headaches, sleep disturbances, and chronic pain. And lastly, we note nortriptyline also manages chronic pain, sleep disorders, depression, and anxiety in long COVID patients. Having discussed nerve-specific medications in the treatment of patients with long COVID symptoms, we now consider other medications that may be of value in patients who are sustaining long COVID that's disrupting an optimal lifestyle. One of these long COVID patient medications includes naltrexone. Low-dose naltrexone at doses far below those used for opioid dependence appears to downregulate pro-inflammatory cytokine production and reduce microglial brain immune cell activation. This immunomodulatory effect alleviates chronic pain, fatigue, and brain fog symptoms in long COVID patients. And this low-dose naltrexone medication can reset an overactive immune system without systemic side effects seen with other systemic immunosuppressive agents. Another potential long COVID patient medication are the SSRIs, or selective serotonin reuptake inhibitors. By modulating serotonin levels, SSRIs have an anti-inflammatory property which may impact immune signaling pathways and reduce neuroinflammation. This can improve mood, help with concentration, and reduce brain fog and fatigue seen in some long COVID patients. Aripiprazole, known as Abilify, is another long COVID patient medication that at low doses, this antipsychotic medication has shown promise in reducing neuroinflammation and modulating dopamine pathways. These actions lead to improvements in cognitive dysfunction and mood disturbances noted in some long COVID patients. So this reset of dysregulated brain circuits may help alleviate brain fog and related cognitive symptoms. Another long COVID patient medication which should be considered is metformin. Metformin, beyond its glucose-lowering effects in diabetes, has an anti-inflammatory and immunomodulatory property that may mitigate metabolic and vascular disturbance seen in long COVID. Observational research studies suggest that its use during acute COVID-19 might lower the risk or severity of post-acute sequelae by dampening excessive inflammatory responses and improving endothelial function. Lastly, intranasal corticosteroids should be considered for patients with persistent olfactory dysfunction that manifests by loss or alteration of smell. These intranasal corticosteroids can reduce localized inflammation within the nasal mucosa and may help to restore smell and alleviate related discomfort that may be seen because of immune-mediated tissue inflammation in the nasopharynx. And in conclusion, regarding meds specifically addressing long COVID patient symptoms, we note the following. Low-dose naltrexone reduces inflammation, alleviates chronic pain, fatigue, and brain fog in long COVID patients. SSRIs are seen to improve mood and cognition by reducing neuroinflammation. Low-dose aripiprazole modulates dopamine, aiding in cognitive dysfunction in long COVID patients. Metformin lowers risk in these long COVID patients via anti-inflammatory and endothelial benefits. And lastly, intranasal corticosteroids target inflammation to restore smell in those long COVID patients who have lost this sensory function. So in conclusion, as we have discussed long COVID patients and ways in which to optimize their recovery, we conclude the following. Regarding COVID-19 pathology, we know it is a viral infection that causes secondary infections. We know that there's direct neuron and CNS tissue toxicity. There is endothelial damage in every tissue. There are SIRS and inflammatory effects which will cause chronic inflammation and tissue damage. And we know that there's thrombosis in the microvasculature of virtually every tissue in the body. So there is every significant neurological complication that is seen due to this pathology and adverse effects noted in every age group. Regarding brain fog and headache, we know that brain fog and headache are common symptoms. We know that headache exacerbations complicate function. In other words, because headaches appear to worsen after COVID-19 infection, other executive functioning abilities can become impaired. We know that the COVID-19 spike protein may be retained in the meninges and bone marrow of the skull. We know that there are structural brain changes with chronic COVID-19 infection that cause atrophy and cell damage. We note that there are also lung and hypoxic changes and blood flow effects that may exacerbate symptoms of brain fog and headache. These include attention disorders, fluency problems, memory, and processing gaps. It is good to note that there are reversible PET scan metabolic changes that are seen to occur over several months while a patient has long COVID, brain fog, and headache symptoms. And we know that there are at-risk groups who sustain greater PET changes, and greater attention can be made to assessing symptoms in these patients. Lastly, we note that there are both structural and functional changes in patients with COVID-19 brain fog and headache, and we know that some of these physiological changes are temporary, which means patients over several months can have restoration of a more optimal set of executive functions that allow them to cope day to day. Regarding long COVID, fatigue, and weakness, what do we conclude? We know that there are chronic deconditioning symptoms seen in these long COVID patients, and these symptoms are like those seen in myalgic encephalomyelitis, chronic fatigue syndrome, ME/CFS patients. These include fatigue, myalgias, depression, and poor restorative sleep. This is found to be related to mitochondrial dysfunction and chronic inflammation. Changes in the lungs and the brain both can cause a feeling of fatigue to be heightened. We know that this is in part related to macrophages and impaired muscle repair. We also note autonomic and cardiovascular dysfunction, noting that some patients with long COVID will have a resting tachycardia as a result. We know that there's a much greater rate of POTS, postural orthostatic tachycardia syndrome, in patients with ME/CFS and those with long COVID. And so we note that there is a multifactorial cause for feeling fatigued and weak when sustaining long COVID as a disease. Regarding chronic inflammation, we conclude the following. Some of this chronic inflammation is noted to be due to retained COVID-19 spike protein in the skull, bone marrow, and meninges. We know that there are autoantibodies that form in some long COVID patients. We see microthrombosis with local ischemia in most all tissues in the body. We observe chronic cardiovascular inflammation that can result in diseases such as POTS and other dysautonomias. And we note that there is chronic muscle inflammation and weakness in some long COVID patients. So we see that COVID-19 infection causes acute inflammation over time and a secondary inflammatory response that can last for months in some long COVID patients. These inflammatory responses are noted to cause what can be significant cardiovascular, chronic, autonomic effects such as POTS and dysautonomias. What do we conclude regarding the patient care of those with long COVID? It's important to accept dis-ease in patients with long COVID and the many symptoms that may occur in each individual patient. It's important to acknowledge multifactorial pathologies both when treating patients and discussing and educating patients about their long COVID disease. It is worthwhile to develop a holistic approach that is multi-pronged, that includes lifestyle changes, collection of data, medications, and accentuating important activities such as exercise and optimal sleep. Patients with long COVID should utilize rehabilitation strategies that can resolve the state of being deconditioned and can improve brain functioning and executive functioning with the use of rehab strategies that include exercise, sleep, and organized activities directed at improvements in mental health and attitude. It's important to adopt a scientific approach with patients for two reasons. One, if the patients can record what kind of symptoms they're experiencing, it may be possible for the clinician to assess and observe trends that might not otherwise be noted. This could lead to changes in therapies and optimizing patient outcomes. The second reason is if the patient becomes part of the clinical team, the individual patient will also then feel some sense of control over their disease as they attempt to resolve the long COVID symptoms over a matter of months to years. And it's important that patients and clinicians accept that reassessment intervals should be at longer time intervals, that is to say between major holidays and not from week to week. This is because the resolution of symptoms may plateau at several phases of recovery, and it's important to just note how the patient has improved over several months, not over several days or weeks. So when considering long COVID patient care, we know that long COVID can be life-changing and challenging. It's vexing, it's hard to understand, it's hard to figure out what is an optimal strategy, noting that for each individual patient, one individual strategy may prove to be superior to others in resolving symptoms. And physician and clinician input should provide greater patient understanding and education. As the patient understands more about their disease, they should be able to collect more scientifically rigorous data that will help the clinical team, and they should understand better what they need to do as an individual in order to feel better day to day and on an ongoing basis. Thank you for participating in this Fern educational session. You can find this video and others on our YouTube channel at Fern.org. Have a good day.